Good evening.
How are you? Good evening, Ritu. Good evening, Tyagi.
Dev, you can start.
Okay, we are live.
Yes, we are live.
So, very good evening, all the respected doctors and our colleagues. At the outset, I, Dev Tyagi, on behalf of Mankind Pharma Limited, welcome you all for the fourth module of NDEC Advanced program today. The topic of today's module is pharmacological management of diabetes through injectables. And we have with us our course director, Dr. Prasanna Kumar sir, to take us through on the same. So I would request Dr. Prasanna Kumar sir to start with the scientific proceedings.
Thank you. Good evening, everybody. Let me share screen. I hope you can see these slides now. Right?
Yes, sir, visible.
Okay, good. So today we are going to discuss a very important module, that is insulin in the management of diabetes. If you look at introduction module 1, then you had the non-pharmacological therapies for management of diabetes, then oral anti-diabetic drugs, non-injectable. Today we have injectable, that is insulin. This is the conflict of interest statement for my presentation. This is my disclaimer. Now, when we see what is it that we are going to learn in this module, initiation of insulin. Why should we initiate insulin? How do we initiate insulin? When do we instate insulin? And there are so many insulin. Which insulin should I choose? Then intensification. Is it enough that we give one dose of insulin? No, we have to intensify to reach the target. Next question is, it is just like lifestyle modification or tablet or anti-diabetic agent. When you start insulin, you have to monitor carefully and regularly and frequently to see that they don't get into hypoglycemia, nor they are in hyperglycemia and achieve euglycemia. Then all right, insulin is accepted. How, when, where, what? Through what? What are the insulin delivery systems? We have got which one you should use, patient preference, doctor preference. Last but not the least, hypoglycemia. Because whenever you start insulin, patient is worried about hypoglycemia, so also doctor. Now this is what the agenda is. Insulin initiation, clinical consideration. When do you start insulin in these patients? Then continued insulin care. Again, how do you continue insulin and intensify that? Then last but not the least, insulin devices, which are patient-friendly, acceptable, affordable, available, and adaptable. Now, what are the indications for insulin use? There are two types of it. One is long-term use, second is short-term or temporary. Again, absolute indication and relative indication. If the long-term, or probably if you look at the largest or the single most cause of initiating insulin is type 2 diabetes of many years when it is not controlled with maximum dose oral anti-diabetic, maybe 3 oral anti-diabetic agents, then you start. Second is type 1. As you know, unlike in any other one, in type 1 diabetes, the day the child is detected diabetic or adolescent or middle-aged, and it is insulin, it is not 1 dose, not 2 doses, 3 or 4 doses. So also, these are the two long-term insulin or long-term insulin initiation. Then you have got the short-term one. What are the short-term? Diabetic ketoacidosis. Then you have got hyperosmolar, hyperglycemic, non-ketotic states. Previously used to say hyperosmolar, hyperglycemic, not ketotic coma. We don't call it coma. It is hyperosmolar, hyperglycemic, non-ketotic states or syndrome. Then there are certain states where you use temporary insulin, that is type 2 diabetes during physiological stress like surgery and infection. Then you have got where you see that it is a relative or even temporary one, where you see pre-gestation diabetes. Before lady gets conceived, you start insulin because tablets are not safe. Then during GDM, gestational diabetes, though some oral anti-diabetics can be used, insulin is the best option. Then there are relative indications where at the onset of diabetes, according to all the guidelines, whether ACE guidelines, NICE guidelines, RSSD guidelines, or ADA guidelines, Canadian guidelines, at the onset of diabetes, if the HbA1c is more than 10%, it is better initiate insulin, treat intensively. So once you do that, this again, a relative and a temporary indication. And if you control diabetes well, 2 to 4 weeks, then you put them on oral anti-diabetic agent, then beta cell will be preserved for long. We are going to discuss these things. Then again, there are many relative indications for insulin, like renal failure, maculopathy, proximal myopathy, and many peripheral neuropathy as such. Initiation of insulin is not as simple as easy as we think in the case of oral anti-diabetic drugs. What are the problems? What are the challenges? One, patient non-compliance. Patient says, doctor, I don't want to take insulin. I'm afraid of insulin. I heard that insulin is the last resort in diabetes, last stage of diabetes. These are all the apprehensions. I cannot take insulin because I'm alone. I'm afraid of hypoglycemia and I don't know how to take insulin. Lack of training and experience, both from the point of view of patients as well as doctors, but today it is not so. Unlike 40 years back, every doctor, whether you're family physician, internist, everybody has knowledge as well as training how to do it. Then, as I said, the concerns of the patient is, as I told you, hypoglycemia. Then they say, doctor, I heard if I take insulin, that probably I will put on weight. Then patient resistance. This is what the very, very difficult thing. How do you convince a patient they should take insulin? If we cannot overcome this, then all your knowledge, experience will be useless. So patient resistance is always there. 90% of the patient resist. They try to say, give me one more chance. I'll come back with control. Why can't I add one more tablet? Why can't I take tablet like others? Then this is one article, Diabetes Care 2004, which said 27% of patients with diabetes use insulin therapy, but less than half of them achieve the recommended A1C of 7%, meaning that the number of patients using insulin is 27%. Now it may be more 30%, but still not even 50% of the achieved control. If you ask me one thing, what is the importance of insulin? In a country or in a state or in a practice, the percentage of patients who are on insulin shows that the standard of care. Somebody says less than 5% are on insulin, that means standard of care is poor. Somebody says 20, 30, 40% his standard of care is good. Because one of the most important things is early initiation of insulin. Now, whenever we start insulin, then doctors ask, what should be my target? Is it fasting sugar? Is it postprandial sugar? Is it HbA1c? The answer is all three are equally important. Then how do we treat the fasting blood? Basal insulin, you treat the fasting. How do you treat the postprandial? If I want to control postprandial, premix is the one. And at what A1C do we start insulin? It may be different for different persons. In pregnancy or GDM, the target is 6%. Even if patient has 6.5, I want to achieve 6. In type 1 diabetes, small children, it may be 7.5 or 8. Elderly people, 80, 90 or 8.5 is good enough. Young persons, my target may be even 6.5. I have many patients where I try to achieve an A1C of even 6.5, provided there is no hypoglycemia. Then we know how to monitoring fasting, monitoring postprandial, monitoring HbA1c. And 50 years back, it was only monitoring the urine sugar. Today, we are not in that stage. We have gone to that stage, what is known as glycemic variability. Standard glycemic parameters like blood sugar, A1c, glycemic variability can be the future target of parameters because you have a monitoring system known as the ambulatory glucose provider. Recent studies have shown that glycemic variability could be the cause of micro and to some extent macrovascular complications and other complications. And by reducing that, you can minimize the complications. So minimizing glycemic variability can minimize the complication as such. Now, what is it that you know? We'll discuss later on. But remember three things. Time in range. What do you mean by time in range? Suppose I see in a day, I want the blood sugar of my patient between 90 to 40. 70% of the time in 24 hours, the blood sugar should be between 90 to 140. That is time in range. What is time below range? It is below 65. Less than 5% of the time in 24 hours, blood sugar should be less than 70. What is time above range? Suppose I say it is 180. So less than 20% should be above 180. This is how TIR, time in range, TBR below range, then TAR, that is time above range, 70%, 5%, 20% is very important to achieve euglycemia, not only to achieve the good fasting control, postprandial, HbA1c, but also time in range, glycemic variability, very important thing. What is the goal of therapy? As you know, our body, the beta cell produces insulin, and the half-life of insulin is 4 minutes. 24 hours, your blood sugar is between 70 to 140 if you are non-diabetic. Same way we try to achieve that by this, and that means whatever insulin you give once, twice, thrice, force or pump, we are trying to duplicate how the pancreas works in releasing insulin for someone who does not have diabetes. When you are non-diabetic, the moment you take food, insulin is produced. It may be every 2 minutes, 3 minutes, or whatever it is. Half-life of insulin 4 minutes, and that's why your blood sugar is always between 70 to 140. It is impossible to achieve that nearer to what is duplicating physiological insulin we are trying to see. Now we know the goal. What is the objective? The objective of insulin therapy is to optimize diabetes management or to achieve euglycemia to prevent complication. This is the most important objective. Now the question is when to start insulin, which insulin, what is the dose, delivery options like syringe, pen or pump, or patient training, very important. If you do not train the patient how to take insulin, how to monitor, then the whole exercise will be futile. So when insulin therapy starts, question is why, I have answered, when, I have answered, how, which insulin, and how much of insulin. Now, when we say insulin, there are so many types of insulin. Which insulin you choose? Which type of insulin you'll give? So we should understand what is basal insulin, what is prandial insulin, what is premixed insulin, what is mixed insulin, what is basal bolus insulin, and we should also try to understand the devices. Basal bolus is known as multiple shots of insulin or multiple dose of insulin, MDI. When insulin, this is what very important, by early initiation of insulin. If your target is 7, is with maximum oral anti-diabetic and dietary compliance, lifestyle modification, once the HbA1c is above 7 or 7.5, you should start insulin. If you are late, the consequences will be probably complication. What are the barriers to insulin initiation? What is physician inertia? What are the patient factors? Which insulin to start? Now, this is one where this study was published in Lancet by the Chinese group, which said early intensive insulin therapy in patient with newly diagnosed type 2 diabetes has favorable outcome on recovery and maintenance of beta cell function and protracted glycemic remission compared with treatment with oral hypoglycemic agent. That is why it showed all the guidelines, as I told you, ADA, ACE, Canadian, NICE, even our own RSD guidelines says, once HbA1c is more than 10, even the day he is diagnosed, please start insulin. Because when the blood sugar is high, 250, 300, the beta cells are shut off. If you take tablet and try to stimulate, they are in shock, they will not produce. Start insulin, give insulin for 2 to 3 weeks like this study, or 4 weeks. At the end of it, gradually start metformin, go on increasing other oral antidiabetic. At the end of 1 month, patient off insulin. If you achieve tight control within 1 month, the oral antidiabetics may work longer. By and large, 5 to 8 years is what oral antidiabetic works. There are exceptions where within 3 years patient needs insulin, but by 8 to 10 years, 80% of the patient need insulin. But I have patients who are being on tablet, very well controlled A1C 7, even after 15, 20, 25 years. They're exception rather than a rule. Now, what are the challenges initiating insulin? Patient attitude. Patient says, I'm afraid of needle. All of you know in day-to-day practice. And then they say that insulin is a threat rather than anything else. Then I'm worried about hypoglycemia. I cannot manage it. The physician's attitude is discomfort with insulin, knowledge and experience. This is what in the past. Today, I'm sure the younger generation like you are not worried or not afraid. You have got enough of knowledge and experience. The most important thing is lack of time. when there are 20 patients waiting in your clinic and you say you have to start insulin, and patient will take a lot of time. He will ask so many questions. Then he says, doctor, I don't know what is insulin. Tell me about it. Why I should take insulin? So you have to educate patient. You have to start insulin. You need minimum 15 minutes to 30 minutes. So if there are 10 patients who have to start insulin tomorrow, Monday morning, then you know how much of time he will spend. Whereas if you say, okay, you are on 2 tablets, 3 tablets, not control, 1 more tablet I'll give, come back after 3 months. It saves time. That is how a lot of doctors, because they don't have time and they feel impatient. I don't have time. There are so many patients. All right, to come next time. Let me see. This is how. Then the most important thing, fear of losing patient. Doctor, if you start insulin, I don't think I will start. And you are afraid at the beginning of your career, this patient may go to another doctor and that doctor may start a tablet and my reputation lost. I'm losing this patient for that. You should never have that attitude. If all of us talk in the same language, whether Dr. X has said insulin, when he comes to me also, yes, what your doctor said is correct. Your HbA1c is high, blood sugars are high. I don't think I can control a tablet. I will also start you on insulin. Then patient thinks, yes, what my first doctor said is correct, and let me start on insulin rather than asking for tablets. Now, these are some of the tips I can give you how to start insulin. First, discuss the possibility of insulin therapy well in advance of when it needs to be implemented. So patients have time to explore and then find out their fears and obtain information. When the HbA1c is 7.5 on 3 oral anti-diabetic, tell him, I think next time I may have to start insulin. Today I have given maximum tablet. If the blood sugar is not controlled, I think I'll put you on insulin. So patient is already ready. Oh, next time, if HbA1c is high, sugars are high, doctor is going to start insulin. Then he says, no, doctor, give me time. I will follow my diet. Due to COVID, I have not done. I have not gone for exercise because of COVID. I will follow the diet, exercise. I have not taken medicine few days. There was some marriage. So I'll come back 3 months well controlled. Okay, fine. I'll give you 3 months. Next time, if the HbA1c is still above 7.5, I may have to consider it. Don't say I will start. Never use insulin as a threat. I may have to consider insulin. So it is already there in the mind of the patient. Check compliance with diet, exercise, and oral medication before starting insulin. Because a lot of people say, my sugar is high because my daughter's marriage was there. During COVID, I did not go for exercise. There was lockdown. I was at home. I was eating. So this is all. So make sure patient has compliance to diet, exercise. He's taking medicine regularly. In spite of that, the blood sugars are high. Then only you can see that you need insulin. Consider use of insulin pens and other devices that do not require syringe. That is because patient has got needle phobia. Whereas if you see that I will give you pens where the needle is so small, showing the pen and see the needle is so small you can't even see that, and it is less painful. It is very thread, hardly any pain. It is less than a mosquito bite. So when you show that, patient gets convinced, yes, doctor, best thing is in the first shot of insulin, whether it is syringe or pen, always see patient takes insulin in front of you first dose. Once you give confidence, I will show you how to take, and you will be able to take. Ask him to take injection first time. Once he takes, doctor, I am very grateful to you. I thought it is very painful. I hardly felt it is so. Again, when you give insulin over arm and thigh, it is more painful, but the skin is thick. There is a fat. If you give him insulin over abdomen, it will be least painful as such. Use devices. Educate a patient regarding the benefit. You care, I am not just giving you insulin for that. If you take insulin, your quality and quantity of life will be better. Your sugar will be better controlled. And the insulin I give may not cause much of hypoglycemia. And your appetite will be good, sleep will be good. And also educate how tablets are not like insulin. You started with half tablet, 1 tablet, 2 tablet, now 6 tablets. It's not working. The pancreas has to produce insulin. Now we are kicking this horse for so many years that it is exhausted. It will not run, it will die. Rest for pancreas is insulin. Insulin is the best tonic for diabetics. So once you say benefits of insulin, then he will be advised, don't use insulin as a threat to the patient. Now, when we start insulin, you should remember the goal of therapy is different in a type 1 and type 2 diabetes. In type 1 diabetes, there is absolute insulinopenia. So that is why you have to start insulin where you will be using multiple doses of insulin like basal bolus insulin. Then the goal to achieve better control of blood sugar levels through accurate adjustment of insulin dose. You have to have a very good one. Whereas in the case of type 2 diabetics, there is no insulinopenia, there is insulin resistance. You use tablet to reduce the insulin resistance, but in spite of maximum tablets or oral antidiabetic, it's not controlled. So continue oral antidiabetic, simple regime, once a day basal insulin, as in the beginning to reduce fasting, or once a day premixed insulin to control fasting and bone progress. The goal would be to see that behavioral changes like reduced calorie, diet, reducing carbohydrate intake, and physical activity. None of them are going to help much in type 1. It is insulin basal bolus. That is why goals of insulinization in type 1 and type 2 diabetics are different. Now, this is what we see. If you see the diabetes, once you see as the time increases 2 years, 2.5 years, 3 years, 8 years, as I told you, by 8 years, 90% of the patients are on insulin. You start diet, exercise, when it is 8.6, then you see metformin, then you say combination role, then it goes on increasing. That is a failure to advance therapy when recommended may delay insulin therapy even up to 8 years. It can happen. It should have started long back. When patient says, no, sir, it's very good control, ask them to show their A1C. Many times they should have started 2, 3, 5 years back. It has never been below 8. They continue to take tablets. And in India, insulin therapy is initiated only when the A1C levels had deteriorated further around 9%. So in a type 2 diabetics with maximum oral antidiabetic, that is 3 oral, never use 4th, 5th, because first to second, there is a great reduction of A1C. Second to third, it is less. Between third to fourth, there is no decrease in that. That's why never use more than 3 oral antidiabetic drugs as such. So that is why with these things, when the A1C is more than 7.5% with 3 oral antidiabetic, that is the time you have to start insulin. Look at this data and you will see that insulin in Indians are different because we have a greater degree of insulin resistance compared to Caucasians because of visceral fat. We have higher insulin levels to a glucose load than others because we take a lot of carbohydrate food. Then stronger familial aggregation with high prevalence among the first degree relatives and vertical transmission to 2 or more generations of Asian Indians diabetes. That is why we see that compared to the Europeans, that diabetes occurs 1 decade earlier. So younger age, that is why we live longer with the diabetes, then we are more likely to go into the oral anti-diabetic failure. That is why the insulin in diabetics in India are different from the others because of these various reasons of higher insulin resistance, high carbohydrate intake, and visceral fat as such. And we are younger when you start diabetes. Diabetes is a disease of 60s and 70s abroad, where it is 40s and 50s. Today, I'm seeing so many patients between 30 to 40. Forget about that. Every week, I see 2 to 3 patients between 20 to 30, obese, software engineers, overeating, lack of exercise, and lot of money. And that is the reason why they have. This is the slide where it was done, known as improved study across India, north, south, east, west. What did it show? What is the mean HbA1c when insulin was started in India? 9.2%. And what is the blood sugar that you see? Fasting of 194 and the postprandial of 285. You should have started when fasting is more than 140, A1C more than 7.5, postprandial below 180. You look at this, you are seeing that by the time it is introduced, it is where this is not, it is also true to South India also. And type of duration of diabetes, 8 years. This is how most of them, if you look at it, the early initiation is not there in our country. And whatever it is, whether you look at north, whether you look at south, whether you look at east and west, most often it is 8 years and beyond when insulin started. And fasting blood sugar 190, postpone 285, A1C 9.2, 9.3, 9.4. That means we are very late in starting insulin. All of us should start early initiation of insulin. Otherwise, it will be too late. Now, I don't want you to see very busy slide like this. Suffice it to say, depending on action of insulin, there is NPH insulin, premixed insulin, 30-70, 50-50, Glargine, which has no peak, basal insulin up to 24 hours, Detimer works 16 to 24 hours, and you have got a mixture which are using it, and regular insulin, which is short acting. Then you have insulin analog, which are very short acting. Then you have long acting insulin like Degludec, which works nearly 40-42 hours, no peak. Then you have got the only combination of insulin analog, that is iodine, that is Degludec, which has got 36 to 42 hours of duration action, and aspart, which is a short acting insulin analog. So many types of insulin available. One size does not fit all. Though all these types of insulin are there, you are the best judge to decide for this patient which is the one which is acceptable, affordable, available, as well as adoptable as such. Then this is what I was trying to tell you. These are the generic names, and this is the trade name, whether it is aspart, lysoprone, glulysin, or the ultra short acting, the analog, short acting regular insulin, intermediate acting NPH insulin, all of you have used. Then you have got long acting insulin analog like Glargine, Detimer, and longest acting Degludec. Then you have premixed, and the only co-formulation available today, both of them being insulin analog, is iodine as per such. Now, what is the difference between insulin? Difference is only onset of action and peak. Don't think one insulin is better than the other or anything. NPH onset 1 to 2 hours, peak 5 to 7 hours, 13 to 18 hours. It has to be given twice a day. Whereas Glargine onset 1 to 2 hours, there is no peak. It works 20 to 30 hours, most often given once a day. Rarely you can give twice a day. Detimer is onset 1 to 2 hours, no peak, but acts for nearly 24 hours. So these are the type of insulin. We had regular insulin, all of us have used this regular insulin. But if you see aspart, lysoprone, and glulysin, they are short acting. Now there is known as FIAP, that is fast acting aspart, which is even peak, which suddenly goes up, comes down. Then you have NPH, you see, works for 18 hours twice a day. You have Detimer working up to 24 hours. Glargine has got even up to 24 hours, I say. Then if you see, these are the insulin, how the regular, rapid acting, and ultra fast acting insulin. Now this is the only co-formulation where you have got aspart, which works 8 hours. Then you have got Degludec, which works not only 24, up to 36, 42 hours also. Still it has to be given once a day, not alternate day. This is how, whether insulin or combination, the best is to see that duration of action, which is important in choosing. Now, what are the rapid acting insulins? You know that it is aspart, glulysin, and lysoprone. What is the advantage? They can be given just before peak. If you take human regular insulin or NPH, they have to given 15-20 minutes before food. In infants, because in infants, mother gives the food, child refuses to take food. She is afraid the child may get hypoglycemia, or the child may get food and vomit also. That's why these insulin can be given even 20 minutes after food intake. That is the greatest advantage of the short-acting insulin. The fast-acting mealtime insulin, I told you, FIAS, can be given at the start of the meal or even 20 minutes later. A long tail of action, more rapid decline during the first 36 hours. So when you take short-acting insulin, it should be absorbed immediately, and then it should disappear from the body. So there is no late hypoglycemia. Whereas when you take regular human insulin, there are chances of late hypoglycemia. You are looking at 2 hours blood sugars. It may be 180, 200, 220, but before lunch, the blood sugar may come down to 70. That's why when you monitor on insulin, you monitor when you give a short-acting or a premix, check fasting blood sugar when you get up, pre-lunch at 1 o'clock, pre-dinner 8 o'clock, because that is the time when it is likely to cause hypoglycemia. Night insulin may cause hypoglycemia before breakfast. Before breakfast, insulin may cause hypoglycemia before lunch. Before lunch, insulin may cause hypoglycemia before dinner. So that is why these are all the ones which are useful in basal bolus regimen, and you can be combined with Glargine, Detimer, or Degludec. The short-acting insulin are the only ones which are used in the pump. We don't use long-acting insulin, premixed insulin. So pump is only short-acting because 24 hours the pump will be infusing insulin. Now coming back to some of the things, like we asked the question, which one we should use, whether we should use basal insulin, bolus insulin, what is the advantage, disadvantage. The basal insulin effective, safe in type 2, uncontrolled oral anti-diabetic. These days, the basal insulin is the one which is used when you start insulin first, no hypoglycemia, one dose. Individuals may not achieve glycemic control because they don't control the postprandial. This regimen doesn't offer optimum control of postprandial. When you use Basal Plus, that means you use basal insulin plus shock tank, it requires multiple doses, 1 basal plus 3 bolus, 4 doses. If you tell at the beginning, patient may not accept. More complicated to support and teach and needs carbohydrate counting. Problems of hypoglycemia, weight gain. More insulin you use, more hypoglycemia. And it needs full patient motivation, requires regular monitoring. It's not you take 3 times insulin. Every day, 3 to 4 times you have to check blood sugar. Premix insulin. This regimen is relatively easy to teach, simple for patient. When they give 1 dose, it controls fasting as well as postprandial. It offers better postprandial control, more effective in lowering A1C than basal insulin, and compliance is better because 1 insulin and 1 dose. That is how patient acceptance will be better with this regimen. Then, suppose you start basal insulin, as I told you already, advantage is simple, 1 injection, and you can continue metformin, gliptin, and SGLT2. Please remember, either you reduce the dose of sulfonylurea half or stop. If you can continue, don't continue pioglitazone. You can continue with insulin, metformin, gliptin, and SGLT2 inhibitor. With basal alone, low incidence of hypo, less chance of weight gain. But the disadvantage is it controls fasting, doesn't control postprandial. You will not be able to achieve A1C of 6.47. So most often when you intensify, you need 1 more dose of insulin. When you start Premix insulin, simple to start with, 1 injection, 1 pen. It controls both fasting, postprandial. HbA1c with Premix will be better than the basal insulin. And the option to intensify is the same insulin. You can start with Premix once a day, then you can give twice a day, morning and evening. 95% will be well controlled. Sometimes you can use Premixed morning and night, 1 small regular insulin before lunch. Some people have also used Premixed insulin 3 times a day. The disadvantage is there's more chance of hypoglycemia. Weight gain is more. Then when you start basal insulin, this is how you do that. You start with basal insulin and fasting comes down. Post breakfast is not controlled. Give short acting before breakfast. Post lunch is not controlled. You give 2nd dose of it. Suppose you give 1 basal, fasting is 120. The post breakfast is 220. Give small dose before breakfast. Suppose post lunch is 240. Give another dose. If the post dinner is also high, then you give another small dose before dinner. So you may give 10 or 20 units of basal insulin, 4 to 6 units before breakfast, before lunch, before dinner. Then it becomes intensification or basal bolus dose. How to initiate? As I told you, if you are using sulfonylurea, you have 2 options. Some people totally stop sulfonylurea, or you can reduce it to half. But you may continue all this. Sometimes patient asks, doctor, I'm starting insulin, why can't I stop all the tablets? No, if you stop all the tablets, start insulin, you have to give basal bolus. And suddenly you stop all the drugs, start 20 units. Next time patient comes, sir, blood sugar was 180 last time, now it is 300. Insulin is not working, put me back on that. So never do that mistake. Please continue metformin, gliptin, and the SGLT2 inhibitors. If patient is sulfonylurea, reduce the dose to half. Then if the HbA1c is 6.5 or 7 or 8.5, depending on your target. So this is what, depending on the patient target, could be 6.5 in younger or 7% in middle age, or even in small children, elderly, it can be 8.5. So main ultimately goal is to have a fasting blood sugar less than 140. Suppose you start basal insulin, fasting is good, then you can go on increasing the dose till you achieve a fasting blood sugar of less than 140. Now, important thing is, if the fasting blood sugar is more than 140, you can start with NPH or Glargine 4 units after dinner, go on increasing till you achieve a goal of 100 or 120. If, let us say, patient is on 3 types of oral antidiabetic, get fasting and postprandial when he is on maximum dose of oral antidiabetic. If the difference between fasting and postprandial is less than 40, something like somebody has fasting 180, postprandial 210. If 180 becomes 100, 210 will become 130. Basal insulin alone is good enough. Whether you use basal insulin like Glargine or Degludec, you start morning or night, there is no difference. Some people think to reduce fasting, I must use it in the night. Not necessary. You can use it before food and after food once a day. If the difference between fasting and postprandial is more than 60, fasting 180, postprandial 280, your basal will not work. Because even if we make 180 to 100, 280 becomes again 200. That is why if this difference between fasting postprandial more than 60, please use premixed insulin. If HbA1c is more than 8.5, you cannot bring down to 7. Premixed is the better. Basal may not work. So there are various types of regimen acid. If you look at the mean fasting blood sugar and when you are using Glargine, how to do it? If the blood sugar is more than 100, less than 120, titration at every digit managed by physician, 0 to 2 units. So also ask the patient every 3 days, do blood sugar, and you can adjust 2 units so that blood sugar is between 100 to 120. When it is 120 to 140 milligrams, you add 2 units. 140 to 180, increase 4 units. If the fasting is more than 180, whether you initiate insulin or you yourself adjust the dose so that you have a discretion to use 6 to 8 units. That means a doctor can increase between 2 to 8 units. Whereas when the patient is given that choice, you tell him, don't increase more than 2 units, because suddenly patient takes 8 units, the blood sugar comes down, he may get scared. This is how patient is given 2 or 3 units of dose adjustment, but you and me, we can increase the dose anywhere between 6 to 8 units. Sometimes fasting is 260. No point in starting 6. And remember one unit of insulin roughly reduces blood sugar by 10 milligrams. If it is 200, if you want to become to 140, 6 units. If it is 260, you want it to reduce by 160 units, you give 12 to 16 units. This is what it is. This is known as forced titrate of insulin. And again, you see bedtime basal insulin, self-monitor fasting 2 days, and between 100 to 122 units, 122 to 144 units, 140 to 26 units, 180 and above 8 units. This is only for basal insulin when the blood sugar is more than 100. So this is how, when you see that in spite of 3 oral antidiabetic drugs, the fasting sugar is a start basal, if the postprandial increases basal plus 1 bolus, and if the post lunch is a basal and bolus. And this is how, when you see from beginning, lifestyle modification, metformin going to basal, basal plus 3 dose basal bolus. This is how advancing from 1 oral drugs, 2 oral drugs, 3 oral drugs to basal, basal plus and basal bolus. This is how it goes. When you see the history of the beta cell, let us say you start here beta cell 100%, and then you see it decreases. Then you detect diabetes. You start lifestyle modification and oral antidiabetic. Then you start initiating insulin. By that time, nearly 30-40% the beta cells are gone. Then you see premixed basal insulin void. Then you adjust the dose, basal bolus, and as needed. This is how gradually it goes down. Then you have to use multiple dose. Many times type 2 diabetics becomes like type 1, where 100% beta cell becomes almost 0. This is how it occurs. So type 2 can become type 1 diabetics when they are totally dependent. They may, if they don't take insulin, they may also go into ketosis. So when you titrate, again, the premixed insulin, if the blood sugar is less than 80, reduce 2 units. Blood sugar 80 to 110, no change. 110 to 140, premixed insulin increase 2 units. 140 to 180, 4 units, more than an 81. So 6 units. This is how do you adjust the dose? The assumption is when you give 1 unit of insulin, 10 milligrams will come down. If you increase 2 units, the blood sugar will come down by 20. This is the assumption, but may not occur. Sometimes you give 4 units, it may come down 50 units. You give 10 units, blood sugar may not come down by even 20 milligrams also. Every patient is different. Please remember, the whole of medicine of diabetes is nothing but trial and error. Patient may ask, sir, give me the exact dose. Nobody in the world can give you exact dose. Every patient is different. It is always trial and error. So if you look at it, starting, as I told you, basal insulin with tablet or premixed insulin or prandial insulin or co-formulation. And you start with basal with oral antidiabetic, you may start one more basal plus regular insulin, or you may see it's not controlled, then you stop basal insulin, you can give premixed insulin twice a day or twice a day. Suppose even twice a day premix not controlled, you can go to 3 times a day basal bolus dose. And if you see you start with premix once a day, go to twice a day or thrice a day, or you can go to basal and bolus. So this is how all these different regime combination can be used, or you can start co-formulation, gas once a day. You can go to twice a day also. Many times I have seen the most effective method may be co-formulation twice a day, but it is very expensive, as you know. Only patients who can afford, and where you think, I have seen many times patients who are on insulin pump, their sugars are not controlled. I have asked them to stop pump and then go to co-formulation twice a day and one regular insulin in the afternoon. They are beautifully controlled. It's almost like a pump as such, you can see. So it is there. So what is the advantage of Basal Plus? One, helps intensify early, adding rapid acting insulin to heaviest meal, then overcoming clinical inertia, because patients start with basal, okay, sugar not, I'll start one more, okay, doctor, after 3 months, look here, it's not controlled, I'll give you basal plus 2 more, all right. And by 1 year, he may be on 3 doses of bolus plus 1 basal insulin. So this is how you see. A normal blood sugar is always flat like this. Whatever you eat, it may be between 70 to 140. But whenever you take meal in diabetes, blood sugar goes up. That is why you have to give one basal insulin, works 24 hours, 3 times, bolus insulin, short acting, before breakfast, before lunch, and before dinner. So how to start? Very rough guide is, you have to use insulin almost 0.15 unit per kg body weight to a maximum 0.5. That means if there is a person who has got a weight, let us say is 60 kg, maximum dose you start is 30 units, or you may ask 15 units, even 6 to 8 units is sufficient. Suppose 60 kg man, you start with 8 units, you are safe, you will not go into hypoglycemia. 50 to 60% of the total daily insulin requirement should be basal, 40 to 50% is bolus, especially if you take insulin pump. Suppose the patient needs 60 units of insulin per day. 30 units should come from the bolus insulin as such. How do you give 30 units? You give him 12 before breakfast, 12 before lunch, 6 before dinner. This is what I will. How do you give another 30 units? You may give almost 1 unit per hour for 12 hours, then half unit per hour. So that's why probably give 1 or 1.2 units per hour between 6 a.m. to 8 p.m. and maybe 0.8 units between 8 p.m. and 6 a.m. because you want to give less. This is how 50% bolus, 50% basal, whether you give multiple dose or even pump. Ideal way to start should be mimicking the endogenous insulin as such, basal bolus or insulin pump, but we cannot use in every patient. That is why the compromised one, start with premix once a day, then premix twice a day. So basic difference is intensive one, that is based in the basal bolus dose, provide 24 hours control, and prerequisites are selection must be carefully because depends on highly motivated patient willing to check blood sugar. And advantages is better control, but expensive and hypoglycemia. What is the problem of intensification? That one dose, basal, less hypoglycemia. If you take 3 doses, more hypoglycemia. Less doses, poor control. So you have to ultimately a balance between hypoglycemia, see that does not occur, and balance between hyperglycemia, poor control. It should be good control with least hypoglycemia. That should be your target. You should also see cost of therapy. Today, one cartridge can cost as high as 1,500. And there is a vial which may cost not even 75 to 90 rupees. I can get for my poor patient 80 to 90 rupees one vial. So 90 rupees, one vial, what I am getting for push patient, compared to 1,500 to 1,800 rupees for a disposable pen. So you have to discuss with the patient cost of therapy, whether he can afford it. You may write, patient may not take. Monitoring glycemic control, very important. More insulin, what doctor had to take 4 times insulin, 3 times I have to check. Communication with the patient to HCP. All right, you have said I have to start insulin. How do I contact you if you get low sugar in the night? How do you adjust the dose? So you should have some person, nurse, diabetes educator. You can do blood sugar, send it to her. She herself can adjust the dose. If not, she will contact me. I will tell. Very important psychosocial aspect. So you have to support the patient that how it is good to take insulin, nothing to worry about hypoglycemia. It is not very painful. Unless you spend time, your patient will not accept insulin as such. Split mixed, as I told you, that usually whatever the dose of, suppose patient needs 60 units of insulin, then you can see that 2/3 of the dose in the morning, 1/3 in the evening, 40 units before breakfast and 20 units before dinner. This is how most of the split mixed do. Again, people are using different 50-50, 30-70. Never use 50-50 insulin in the night, it may cause hypoglycemia. 50-50 premixed is meant morning before breakfast. 30-70 are the basal insulin can be used in the night to prevent the hypoglycemia. Now, what are the benefits? You asked that you have human insulin. Previously, we had animal insulin. Then we had human recombinant insulin. Today, we have analog. Is it better to change everybody to analog? No. The advantage of analogs are meal time and meal size flexibility. If just before meal, you can take that injection, within 5 minutes you can eat. Whereas if you use human insulin, you have to wait 15-20 minutes. Many times patients forget, and then 30 minutes they are not, they get into hypoglycemia. That's the problem. And analogs are more physiological replacement than regular insulin. Late hypoglycemia is less with analog. Better postprandial control, better patient and parent satisfaction, and it is suited for subcutaneous insulin. Availability in pens make them insulin therapy patient friendly. Most of the analogs are available are pen. Very few are available are the syringes. Now, what is the disadvantages? Lack of data superiority. You cannot say analogs are more superior. No, when you change from human insulin to analog, 10 units of human insulin is equal to 10 units of analog. Don't think it is more powerful, but 2 to 3 times costlier. Availability, if we are in a city metropolitan, you get, if you go to taluk headquarters, you get only human insulin. Sir, this is very expensive. No patient is willing to take it. There are many doctors who are not. And somebody wants to take it, is not available while. So these are the disadvantages of insulin analog. You are the best person to decide whether human insulin, analogs, whatever it is. Discuss with the patient cost, benefit ratio. Now, this is what we said, that most important thing is hypoglycemia. EADS is level 1, level 2, level 3 biochemical asymptomatic. When the measurable glucose concentration less than 70, more than 54, that is level 1 hypoglycemia. A blood glucose content 70 has been recognized as a threshold of neuroendocrine response for falling glucose in people without diabetes. Hypoglycemia is considered asymptomatic or biochemical, symptomatic or severe. How to prevent? Educate the patient, tell them what are the symptoms, how to prevent it, and why it causes, and even if it gets, how to manage, very important like that. If you see all the diabetics, the prevalence of diabetes, this is a retrospective analysis of that, and prospective. In type 1 diabetes have maximum because they take basal bolus. Then you see all other diabetics get whether retrospective, prospective studies, hypoglycemia count. Less common in type 2 diabetics. Then you see nocturnal hypoglycemia, again more high in type 1 diabetics. Then you see type 2 diabetics and others as such. Severe hypoglycemia also. The symptoms of hypoglycemia, you should tell the patient, if you get these symptoms of trembling, palpitation, sweating, anxiety, increased hunger, nausea, and if you get the symptoms like difficulty in concentrating, confusion, weakness, drowsiness, blurring of vision, and dizziness, this is symptom of hypoglycemia, neurogenic or neuroglycopenic as such. What are the causes? If you take by inadvertent, the other day, One of my relatives took 50-50 in the night and 30-70 in the morning. So what happened? She went into severe hypoglycemia. So too much insulin or too much of sulfonylurea. Exercise without adequate food intake, skipping meal, lack of glucagon. If alpha cells are also damaged, then hyperglycemia cannot be managed with glucagon, they get it. Excess of alcohol intake, that can also cause hypoglycemia. If even a non-diabetic with insulinoma can get hypoglycemia. What are the risk factors for hypoglycemia? Endogenous insulin deficiency, which predicts deficit glucose response. Both beta alpha cells are destroyed. History of hypoglycemia, unawareness, very dangerous. Long-standing diabetes, because of the sympathetic nervous system is destroyed, they don't get symptoms. Suddenly they become unconscious. I have seen in my clinic many times blood sugars are 40. Patient says, sir, I am not aware. Aggressive glycemic therapy, as evidenced by lower goals, lower A1C, and recent moderate intense exercise. One day patient thinks, today let me walk 1 hour, and he has not taken food, and sleep and renal failure. Patient is taking 40 units, he gets hypo, becomes 30, 20. Doctor, last 3 months I have stopped insulin, my blood sugars are good, my diabetes is cured. He has got from bad to worse, because once there is renal failure, especially albuminuria, the endogenous insulin or exogenous insulin works longer. That is how they get into hypoglycemia. If there is a sudden decrease in insulin requirement, you should suspect renal failure. Monitoring, which to monitor everything: fasting, postprandial A1C, ambulatory glucose profile, capillary or venous, yes, whatever it is. And you should use a glucose meter. Whenever patients start insulin, ask him to buy glucose meter. Don't call it glucometer. Glucometer is the trade name of Amis company. It should be called glucose meter or reflectensometer. Which blood sugar to that? Fasting, pre-lunch, pre-dinner, because hypoglycemia occurs at that time. So this is what we feel. Frequent measuring of blood sugar, adjusting one, the self-management of diabetes is very important. So when the patient is using pump, he has to do at least 4 blood sugar. And if he is treating with single injection, at least 1 to 2 blood sugars per day. If he is being treated with secretogram like sulfonylurea, if he gets hypoglycemia, then only he should. Whereas if the patient is on drugs like metformin, leptin, SGLT2, he need not buy glucose meter, he need not monitor. This is what I told you, ambulatory glucose. One monitor known as Freestyle Libre. This is the sensor. You attach it like a 1 rupee coin here in the arm, and it will check blood sugar every 15 minutes. Needle is already there. You can see this is the needle. And once it is there, it works 14 days, 90 blood sugars per day, every 15 minutes, 1,600 blood sugars for 7 days. And this is how you see. And 13th May, patient is getting hyperglycemia, average 186. And you can see here only 29% time in the 6% hypoglycemia, 65% hyper. By 8 June already, less than 3 weeks, see the curve absolutely flat. 186 average came to 114 and 87% is range, hardly 2% above range. But the problem here is the hypoglycemia increased to 11%. Very useful in detecting hypoglycemia, fine-tuning the insulin, ambulatory glucose profile. In one of the future modules, technology will talk about it. As you can see here, from glass syringes to disposable syringes, and then you see the pens, and then the pumps. All these shows how even including the what we call it as the closed loop system or artificial pancreas approved 2-3 years back. That is the ultimate, where the whole basal insulin is taken care. You fix 90 to 140. As soon as the blood sugar comes drop down to 100 to 90, the pump stops. As soon as blood sugar crosses 140, pump is on. Only you have to calculate the carbohydrate, adjust the dose for breakfast, lunch, and dinner. Otherwise, 24 hours, the pump will talk to sensor, adjust the blood sugar. We'll talk about it later more. This is what you should be familiar with. The red cap, and this is U40, and the orange cap is U100. Never use the vice versa. If the vial is U100, that means 1 ml contains 40 units, use U40 syringe. If it is U100, then you should use this syringe, the orange one, because it is marked 1 to 100. You must use only insulin where 1 ml contains 100. Of course, there are pens. Advantage is more accurate, more convenient, improved compliance. And nowadays, there are advanced pens. There is a LCD display. Once you take insulin, how much of dose has gone in, you will know. So the ideal pen should have a dose accuracy, durability, convenience, and safety. You can carry here without refrigerating because it gives accurate dose, safe. You can dial back once you push, it goes to zero. Lifelong, this pen can be serviced and convenient. And even people who are blind, when they take insulin, or you see, will get a click. One click will be 2 units. So these are the advantages: better control, better acceptance, eco-friendly. If every day somebody takes 4 syringes through, imagine what is the effect on that. This is the pump where there is a reservoir, basal bolus 1, and you can have the pump like this. And this is how from the portable pump, which is so big, now you see the pumps are almost as small as a mobile phone. To summarize my talk, early insulin therapy will preserve beta cell. Early intensive therapy is necessary to prevent macrovascular complications. Normalization of HbA1c below 7 should be the goal wherever possible. Insulin devices make insulin acceptable, and insulin remains the most powerful agent. The best tonic for a diabetic is insulin. Initiate and intensify to achieve the goal, and both basal and premix are useful in initiating. Insulin pen devices are user-friendly, better compliance. Basal insulin only when high fasting blood sugar, and if PP base is not, use premix. Thank you for your attention. I know I have taken almost 55 minutes because this is a very important module and everything is important. And if you have any question, please put it in the chat box. I will try to answer to the best of my ability. And over to organizers for the questions.
Thank you so much, sir, for such an insightful session. So we have a couple of questions. The first question is asked by Dr. Venkatesh. Is it more effective if I take my insulin in the morning instead of evening?
The question is a very good question, Dr. Venkatesh. If it is basal insulin, it does not matter whether you take morning or evening, because the basal insulins like Glargine and Degludec have a long life of 24 to 36 hours. It does not matter. Whereas if you are using NPH insulin, if the fasting blood sugar is high,